I would like to thank all three of the moderators for really excellent summaries, great ideas coming from the group, and some potential new approaches. Some of the words that I heard that came through repeatedly across all of them: community, equity, sustainability, implementation, and implementation science, data, multisectoral. I mean, I think there are many themes that we have heard repeatedly. But I would like to open this up for general discussion. Again, so many good ideas, and some of you may want to flesh out some of them, including the moderators who may want to comment on those from the other groups. Toward the end, and we have plenty of time for discussion now, but I would like to spend a few minutes at the end thinking about priorities. I mean, there are just so many good ideas, but if we want to be useful, it would be helpful not only to have some concrete ideas for research activities, but also some ideas of priorities. But anyway, let me throw it open.
So first of all, really great session. Maybe this may not be quite so concrete, but maybe something that could frame the concrete ideas to follow. Between yesterday and today, we heard, a number of interventions, of ways of trying to do things in a societally appropriate way, reflecting the needs and challenges of different areas. But as we think about sort of, if we bring it back to microbial threats and how these slums and all the associated aspects kind of feed into the spread of infectious diseases, I think that as we consider all these interventions, whether the ones we've discussed or ones to be discussed, is that we need to think about in parallel is how we assess whether or not these interventions are truly of value. Can they be generalized or not? One approach in Kenya may not be relevant in South America or in the Indian subcontinent. And so I think the ask is that for all these potential interventions that we think about harmonizing it with an operational or implementation research component, so we can really get a sense of what's being proposed, if it's truly of value, or it's just not fire and forget, right? We need to see if it really works.
Any of you like to comment?
I think it's a great point. We did talk about that. I think, though, flushing out together what we mean by what works and for whom, over what time frame, what outcomes are we seeking? Because I think we heard throughout this workshop the co-benefits of focusing on maybe a particular exposure or disease can also have social, economic, a longer community benefit, community development. So I think this gets to, the common theme that ran through all three of our sessions really was really flushing out in much more depth, as you're suggesting, the implementation and evaluation science behind this, and what are we measuring, and how do we know it's working?
We did have some discussion about what we would measure and whether or not that would be limited to public health outcomes. We didn't think that it should be, but I don't know that we knew exactly what those things would be that we would measure. We did have, as I indicated, a discussion about within public health programs, things like randomized control trials are considered a gold standard for assessing effectiveness. But effectiveness is not necessarily what happens in the real world when you implement things. And so there's a whole sort of sequence. Do we really need to do randomized control trials if what we want to do is improve infrastructure of mega modern cities? So there were some, there are unanswered questions, but there are things that we don't have an answer to it. But we do think that an evidence base is really a critical part of that process.
I could perhaps just add to that and add to the remarks I made in the report. If we are to build an evidence base, we need to characterize the quality of the evidence. It will be very mixed, from essentially anecdotal through to much more formal, even randomized controlled trials, although I think the RCTs, although they've been promoted around implementation research, they have a number of persuasive champions, and in some regards, they're likely to be in the minority. And very commonly, we're going to be making judgments from real programs that took place on the ground, and we're going to try to have to make sense of what the underlying causes were for success or failure as appropriate. So the classification of different kinds of evidence, I think, would be an important piece of work to do as we bring together a body of case studies, not just to say, here's a long list of case studies, but here is where we think this case study lies in terms of the validity of what is said about that case study, whether it applies only specifically under that setting or whether it's likely to be generalizable to other settings. Now that's a huge body of work for somebody to do, but if we had it, it would be a very valuable resource.
So yeah. So, Chris, are there examples of that you can think of? We did have some discussion in our group about some examples, but I wonder if there's something you could think of that we could take a look at how people approach that.
Two kinds of answer perhaps to that. We know, I mean, the one thing that I would do in the first instance is I would survey the databases that are already exist for what works. Now, I refer to the one on UN Habitat. I'm sure that there are many more. We have some within WHO, but I'm sure there are many, many more. I don't have a systematic view of what the relevant databases are in the first place. Secondly, the way we classify information in WHO, at least at the more formal end, it is very formalized. For example, around when we develop guidelines, so essentially WHO recommendations for good practice in any particular setting, then the approach to developing guidelines has very specific ways of evaluating evidence. So I think there are some lessons to be learned from those systems for evaluating evidence, and we have a series of very specific series of terms around evidence that have very precise meanings and are well defined. But I would also say that that is actually only used for only a small proportion of what WHO worldwide produces in terms of guidance and recommendations. However, it is there as a starting point. And of course, then there's other guidance, the Cochrane systematic reviews and others. They tend to be at the formal end. We might be dealing with a lot more informal evidence, and a discussion of how to handle that informal evidence would be, I think, important to have.
And the complexity of what we're talking about, the number of different players with different perspectives and priorities, it may be that we're headed into new territory.
I would like to open it up to the non-forum members as well. I mean, the rest of you were also involved in the group meetings. So if there are comments or questions from those of you who are not sitting at the table, please go to the microphone.
Thank you. I want to thank the moderators, and particularly Chris, who moderated our group, for doing a wonderful job of summarizing what we discussed, and I'm sure the other moderators did as well. This is actually sort of a promotional announcement, but I think it's relevant to the topic at hand. This is a newly released in October, Global Roadmap to 2030 for Ending Cholera. And this is a product of the Global Task Force for Cholera Control, headquartered at WHO's. 2030 was not a coincidence. It's very much tied to the Sustainable Development Goals for WASH, for health. Not necessarily for cities, but when you read the plan, it's pretty innovative, and I think could be leveraged to improve health in informal settlements in cities. What they propose is to bring together those short-term and long-term solutions. We mentioned, Tom, you did the large-scale infrastructure and the long-term and the short-term and how we need both, but to do so in a very targeted manner. So this is not wash for all or anything quite that ambitious, which is its own SDG, but it's targeting large-scale, long-term infrastructure along with short-term cholera vaccines to the small proportion of the world that has really, really high incidence of cholera and really, really high transmission of cholera. Those are not necessarily the same spots. Some are high incidence, some others are not so high incidence, but they amplify and things spread out from those places to other parts of the country or other countries. We have a lot of cholera in sub-Saharan African cities now. We didn't used to. For a while, it was rural disease. Things in general, coverage with water and sanitation are higher in urban than rural settings. But I think with the growth of informal settlements, peri-urban areas, there's a growing population that's vulnerable to waterborne diseases, cholera being sort of the first one in cities. And I think some of the districts that they will identify as these hotspots will be the Caberas, the other large informal settlements where they have had cholera, and the potential for a big epidemic is very real. So I'd just like to say, if any of you are interested in this or in how it can be used, I'd be happy to talk with you about it. I think the folks at WHO and other groups, UNICEF, IFRC, that contributed to writing this are thinking along the same lines you are thinking, in tying together multiple SDGs and leveraging that momentum to try to do something longer term and intensely focused on the most vulnerable populations. Thank you.
Thank you, Eric. David?
Thank you very much, Mary. I'm sorry I came in late. I was just thinking. I wanted to pose to the three leaders, but also in a way to the wider group, a hypothesis that I've been developing today, and to ask whether or not that hypothesis holds in people's minds, and if it does hold, then what does it imply for the sort of advice that we would give to our own institutions, but also give to outfits like the World Health Organization or UNICEF, or even to national governments. The hypothesis is as follows, that there is a new narrative on how best to contribute to better health of poor people dwelling in the world's cities. And I stress, not just the cities of developing countries. The first is to be ready to refashion interventions such as water and sanitation from the viewpoint of the user and also from the viewpoint of the different sectors that are involved. The second is to reform implementation so that community ownership and leadership is at the center, and the role of statutory bodies is to facilitate and sometimes to nudge progress. The third is to renew engagement in this work so that instead of seeing it as primarily the role of the government or the role of the municipality, that there's a range of actors, private actors, both, as Chris was saying, the small-scale entrepreneurs as well as larger businesses, civil society, faith groups, obviously scientists and others should expect to be involved. And the fourth is to review financing. Although we didn't talk about it in detail this morning, it seemed like most of the interventions and actions that were being described were not all about big grants doing big infrastructure. There was actually often a lot of use being made of resources within local communities, very small amounts of resource in order to make a change. So those were the four sorts of things that I heard. And it resonates with what I've learnt in my own work, particularly in the last 15 years. And it is a different narrative, and it's a different way of working from how urban work has conventionally been done. And it's certainly not working on separate programs and vertical action. It's community leadership, horizontal, multi-stakeholder, and very much built around a narrative that reflects what people want. Now, if that's true, then I think it has huge implications, because although our presenters were able to describe what they've been doing and to show the results, it's not still sort of commonplace in development practice to work in this way. It's coming. But if that is the way to go, then some of the points in what our groups have been saying, particularly about the skills needed for doing this kind of work, are really important. So you don't just need to be a really hot entomologist or an extremely well-skilled engineer, but you need to be a person who has real expertise in working with community organisations, like we heard from Dr. Agarwal this morning. So that has implications for the skill mix, it has implications for the way in which you go about it, it has implications for the business case, it has implications for the general approach. So I just wanted to ask the question, is this a new narrative? Is it there? Are we confident that it is, if not the way to go, an alternative that needs to be considered, and what's the implication of that?
Thank you very much, David. I'll ask the panelists to comment, but then open it up to others in the room who also want to comment on this, particularly some of you who have worked in communities.
I think, David, we have the beginnings of a new narrative, is my reading of it. Not yet a sufficiently formed narrative to say this is the new way of doing business in development. And what I fear in taking that step too quickly is that we will make mistakes that we've seen in the past, such as the sudden decision that structural adjustment is the way forward, under the influence of major funding agencies, the World Bank or whoever it may be, that we jump too quickly towards a general model of development, whether it's in urban areas or more widely, which is not necessarily justified by the evidence that we've been talking about. And you used in your proposal the word hypothesis, which is perhaps exactly the right one to use at the moment, in the sense that hypotheses are there to be tested. And my feeling is that while we've heard many, many good things about this subject, we're at the stage of still testing those ideas. And as I think all three of us said, in reflecting on the group discussions, there are lots of good ideas at various stages of development. We don't know whether those ones that work in that particular setting, or whether they could be generalized more broadly, so that ultimately we could say this is the way in which you do this sort of development in this sort of environment. So my answer to your question would be, we're at the beginnings of a narrative the way we develop that narrative is by testing the various hypotheses that we've seen.
Yeah, I think I would add to that there seems to be a general consensus that this is something that people think is worth pursuing and that it would have a positive impact, but exactly what the component parts of that would be and how we would go about it don't seem clear to me. And that's why I think this idea that our group talked about in terms of a workshop as an extension of this meeting might be a good way to proceed. So we had people in our group who work on development of cities in the future and so forth. They said this is one of the first times they'd heard people talk in that context about health. So to identify who the important players are in those fields with the various expertise and bring them together seems like it would be a worthwhile next step. But this is a different way, certainly from the way that I've thought about it. This is a different way to think about substantially improving public health, not just of people in urban slums, but people in general. And we are seeing more and more people move into urban environments. And I agree with Chris. I don't think we want to move too quickly, but I think it would be worthwhile. I like the idea of doing a systematic review to see what kind of information there is, and are there examples, are there things that we could learn from. That would be helpful rather than starting from scratch.
I want to maybe take a slightly different approach and suggest we shouldn't take a slow approach, that we ought to take a much more aggressive approach, not that we don't want to measure how we go, but the crisis of health and inequalities in cities demands much more attention to, I think, what you're suggesting, David, as a framework for process, not necessarily directing the product or the outcome. I think we do need to commit to that, and we can look at 50 or more years of evidence in the literature of, say, community development, where participatory community economic development and a whole host of things in cities have shown the kinds of methods and the positive impacts of some of the things that people were presenting, Dr. Agrawal and Dr. Harris and others this morning. So I would say that, yes, I agree with your framework. I would say it's not necessarily new, maybe it's new in certain areas of global development or global health, but there are many other fields where there's a long history of looking at this type of participatory practice. I would agree that we do need better tracking and evaluation and metrics to track the multiple impacts that we're hoping for. But I would say, no, we shouldn't go slow. We should go faster. I like the idea of piloting in particular places and setting that up in a really engaged participatory way. But we need to build the evidence base by doing, not by just studying.
Eva, you were nodding. Do you have anything you would add? I saw you were nodding your head as, no, Eva.
Yeah. No, I was resonating with what? Oh. No, I was just, the learning by doing, I guess it's something we always say in ours, which I had not mentioned, but that you did, so I was glad about that. And I mean, I'm not operating at the level of the WHO and at the world level, so I appreciate those who do. What?
They are too high.
No, I mean, I think there is evidence, and I think I do think that we should push forward and try to bring certain of these to scale. I mean, that's the only way we're going to find out if it actually works. It doesn't have to be the whole world at once, but I think when there is cases that have evidence and that can be pushed forward, I mean, the big challenge for me is the scale up, and is the scale out. And I think that, as hard as it is to get there, that's the easy part, what we've done so far. but I also think that there's only so much that can be done theoretically, and that, one just has to kind of push forward and try to make this happen in a new, I like the idea of a new narrative that, I mean, it's not necessarily a new narrative, but I guess it's getting more traction in more traditional places, or maybe that's the way to frame it, and I think that, I have noticed over the past 15 years that there is, more acceptance of these approaches in more and more arenas, at least in, my area. So I would just say that it's worth moving them forward when there is an evidence base, and then trying to have that serve as a example de facto, for other areas, that are coming along. And learn from others, right? I mean, from the HIV story, from the polio story, I think that's really, really important. We've learned a lot from, certainly HIV and influenza and other areas that, have been ahead in various different kind of scenarios. So I think we should learn from that, but move forward.
So I don't know if we necessarily do disagree, but I think we need to be careful about learning by doing, because you can do things poorly. And I don't think that's a way that we want to learn. I think we need to be very careful in terms of the kind of evidence base that we have. There may be, I don't doubt that there's people in other fields who have been working on this for some time, but in the kind of public health I deal with, they haven't. And so I do think we need to sort of bring people up to speed in that regard. And I can think of a number of examples where people with good intentions went out and did things and they wasted a lot of resources. So I think we need to be careful that we do it in a way where it really is informative, and that there isn't unintended consequences to already vulnerable populations. That would really bother me.
I didn't mean learning by doing at like a global scale. I mean,
I don't care what scale it's at.
No, but I mean, like, the pilots that when you, for instance, like we discussed, you don't necessarily have to have a map forward. It doesn't have to be prescriptive to the level of detail. What I was trying to explain is that, we learned certain things from a pilot phase that then served as the principles for the next phase, which in our case was an RCT. But it wasn't saying like every person has to do exactly the same thing. It was saying, as we discussed in our group, you need to follow certain principles, but the details of that can be left up to the community. And there you have a strong, rigorous methodology, but at the same time, it's not a one-size-fits-all kind of thing. But, as you do that, you do learn, the community is learning by doing what is going to work, in their community at that level. That's kind of what I meant is, kind of bringing it into practice. But then in this case, I think in certain cases, there is an evidence base, and in some cases is based on RCTs, in which case that could then move forward to try and, find ways to make it more scalable, either working within, in our case, for instance, the existing structures of the Ministry of Health, or, in other countries, through student organizations or what have you. But it's going to lend itself, and I think that trying to push it so that it doesn't stay at the level of a study or a trial is an important next step, is kind of where I was going. Not like suddenly saying this is what, WHO says everyone has to do. I mean, we're definitely not at that stage.
Chris, you're not at that stage? Just kidding. What I see, what I see is that we're sort of between, we see an urgent need that we want to address as quickly as we can. On the other hand, we want to make informed decisions, so we want the appropriate evidence base to be able to do that. So we don't want to hold things up that would be helpful and keep doing RCTs, which are expensive and time-consuming and not necessarily provide all the information we want. But on the other hand, we don't want to rush into this without having the kind of information that makes informed decisions. So it's a interesting place to be between those two things.
I'd like to add to that. The conversation we're having at the moment is still somewhat a top-down kind of conversation. As people speak, I'm thinking of other initiatives which have been self-propagating in communities, that have been generated within communities, or perhaps with different intentions, that have spread very quickly. One example is M-Pesa, using mobile phones to make payments, which is an idea that was launched in South Africa with a completely different intention by a telephony company. but which, when spread to Kenya, was discovered as a way of making transactions among people in communities that had never been imagined. And once people discovered that, it spread very quickly indeed. And then everybody else was catching up. And that's one example of a general phenomenon, which is that good ideas spread through communities on their own. They don't need to be driven by external panels of experts who make decisions about whether there's good enough evidence or not. There are self-driving or self-propagating innovations that spread through communities. And I've heard very little said about that sort of innovation and how that works. I think that's an area that we need to take note of as well.
Yeah, thanks very much. I have just one quick comment and then a question. So the comment, Chris, you did a great job. We didn't get a chance to discuss in our group. Perhaps maybe 5 years ago, there was a big push, and still is, in terms of advancement and adopting social responsibilities in corporations. And their language is really, about business cases. And so I don't think that's a negative connotation. I just think we have to learn to do it better. And to talk about that social responsibility. People really want to do the right thing, but I think we have to talk in that kind of language, I think, to get it done. So maybe Jay or Kent can talk about that, but I think it's important, and there's an awful lot of money there, and our ability to, to gain access to that. So my question is maybe for you, Tom, in terms of scaling up, because I didn't see it in your list, I probably missed it, is more about entrepreneurship. So we know these communities are really clever. They really are, to be able to survive and sustain themselves over time. So I was interested in what Danielle talked about this morning, these kiosks, these water kiosks. And certainly I've seen in rural settings, in rural poor, that bringing together poor livestock keepers and moving them together to create markets have really done a lot to advance marketplace and put money in people's hands. And why that's a poverty reduction, it also improves health. So is there more thinking or more possibilities of really entrepreneurship and it really engages that community, and how that might be helpful, and maybe some other people would have comments?
I think that's a really interesting idea. There was a little bit of discussion about that, but I don't think it was specifically touched on. I don't know if others, Jay, if you remember anything about that, David? I think that, but I'm glad you brought that up. That's a good point in terms of scaling up. And like Eva said, I think this is one of the really critical issues in the process, is taking something that we have a proof of concept for and then doing it at the scale, time, and space that's going to have the public health outcome we're looking for. Anybody else in the group? There was some discussion on it, but no, so we should add that to our list.
So as we talk about, generating evidence about what works, I was intrigued by, I think it was Jason's summary, one of the groups, where there was a discussion about the need for and role of big data. This forum had a meeting on big data and public health, I think less than 2 years ago maybe, in which we heard some remarkable things. And the city of Chicago was modeling multiple factors like outbreak of foodborne illness in near proximity of restaurants and exposed garbage to target their rodent control efforts, and showed a 20% increase in efficiency of rodent control, as I recall. And we heard about using Twitter to identify foodborne illness services and cell phone lines, as we heard yesterday, for tracking mobility and influenza epidemics and the like. And I was wondering, and this is sort of an observation, this is more a question, than an observation. So there are a lot of these experiments, whether it's a water kiosk, whether it's different types of EDs control or whatever, different communities are doing different things, and public health departments collect lots of data. Data is not cheap to collect, but it's probably cheaper than intervention trials. Is there an opportunity out there to learn a lot more about what works just by really accumulating the data that exists and analyzing it?
Yes, it's a, there's, in some places, in some contexts, there is a real wealth of data that's available. It's just not, haven't necessarily been analyzed or analyzed in a way that relates some of those interventions to health or health determinants. I think what we particularly talked about was places where there's great opportunity to increase the data that's specific to both populations and places that are either unrecognized, understudied, or not captured in a lot of the ministries of health. And so I think we agree with your comment that there's a lot of, there's great opportunity, but there's sort of this inequity in big data. And so how do we as a group possibly weigh in on that? I know maybe Siddhartha or Alex, who you had talked about the importance of some of this sort of urban slum specific data collection longitudinally. I don't know if you wanted to also respond to this comment.
I think that's one of the points I was trying to make yesterday, that if we actually, in the 2020 round of censuses, if we can get countries to identify urban clusters and whether they are slums or they are non-slums, it creates and opens a new window of opportunity to really begin to understand what is going on within slums. One of the things we've not really looked at is we often focus in our study around slums on the big cities and the mega slums. But what we are not paying much attention to are the smaller towns and that's actually becoming 100% slum in a way, because they are growing very rapidly and they're unplanned without many of the urban services. So if you think about decentralization happening and the growth of these smaller towns, that's really where the biggest challenge and threats will be. They are much closer to the rural areas and also feed into the urban with very strong connections in many ways. I think we saw some conversations around that yesterday. So how we deal with that and how we incorporate that in our thinking around urban systems becomes quite important, because the dynamics are so different from what you get in the big cities.
Can I just
Albert?
follow up on that and then change focus a second? But no, I think what Alex said is extremely important. If you look at trends in urbanization in developing countries, it's not, a lot of the growth is not in the large, well, depending on which region you are, not in the mega cities have capped out, and it's really in these mid-sized cities. And those problems are qualitatively and quantitatively different from those in the mega cities. So I think his point is an excellent one, and one that we didn't really talk about or differentiate. Is it okay to shift gears a little bit? I wanted to get back to what Peter said. Peter said about the close proximity, between, wealthy and slum communities in urban setting. The geographical distance may be very short, but the social distance, and I think this is just the essence of the driver of many of the health problems, is the marginalization. The social distance is very long, great, and we haven't gotten it right. I mean, if you look at externalities in health, probably the most compelling is violence. And, if you look at our own situation here in Washington, D.C., or inner cities or whatever, we haven't done a good job of not only understanding those externalities, but also getting at root drivers. I think that's probably one of the biggest failures in the last 50 years in terms of urban slums or urbanization. And I have a second point, but go ahead. Yeah.
Well, I'm glad you came back to it, because to my mind, I said this in the context of how do you make the pitch? And actually, David said to me, you've got to why call it a business pitch? Why not just a business case? Call it a case. And this is about talking to the powerful in countries where they're living juxtaposed against this extreme poverty and unhealthiness. And what is it that's going to drive them to actually do something? Violence, it's interesting, when we think about violence in a city in the US, we think, well, that's a crazy place, you've got to avoid it, don't drive into it, it's a nightmare, Baltimore, how do the police cope with it? What we don't do is, you're right, we don't round it out and say, well, something about the design of our cities, about the way we're inequitable around healthcare, or violence mitigation means that we suffer. Bringing it back to the policymaker is what I'm talking about, and I can't believe it doesn't work. Maybe we're not doing it right. So I'm glad you bring it back.
So that brings to the second point, which, and I think, Tom did really a wonderful job in synthesizing all the ideas and making it coherent. I think there's one nuance in the issue. I think there's all broad consensus of the importance of interventions to, to promote equity and to address, issues of inequity, given it is the important driver. But I think there's also another point in that logic or in that rationale, which is really the issue of equity in the interventions that we choose among all the ones, and the equity in implementing those. And I think it's really getting at the issue of, avoiding poor solutions for poor people. And we know this, and this gets back to the issue of violence. We had poor solutions for housing for poor people in the 1940s and the 1950s, and now we're suffering 60, 70 years later those consequences. And this raises the point that was kind of brought up earlier. Doesn't Kibera deserve closed sanitation systems? Why do they have to work on portable toilets or things? Things that we know work, that we don't need to get any more evidence. But why do we have to justify new innovative solutions, but for which perhaps are inferior solutions for people? Maybe you'd like to comment. Yeah.
Particularly within the household water treatment sector, we're asking people to treat water at the household level. I mean, one of the things we often say is we're asking the most marginalized people with the least education to do the most for the water. And if I turned off the water today for all of us, how would we know how to treat it and do that? And so the expectations we have of those at the bottom of the pyramid who aren't getting reached by government are actually the highest. And that's unfair. That's an inequity. And there's a question of how much this comes down to governance, and what do we do for populations that are not being supported by their government? Either because they're a minority that's not being supported, or they're in a slum and they don't have land tenure, so they don't want to put in systems. What do we do for those populations in the absence of governance? And I think infrastructure depends on governance, right? It depends on large projects and governance, and to me, there's an inherent inequity. And sometimes I think I should give up all this wash work and I should just work on better governance. And you know what I mean? Like that's actually, I'm just solving the problems I'm just like, the root cause is poor governance. And that's so I completely agree with everything you're saying. And then part of it is, and there's all these debates about short-term and long-term. And I'm like, yes, we need both. And my particular choice for my work is to work on the short-term solutions, particularly in areas with very poor governance, right, and emergencies. But I don't think that's but that's not the whole problem. That's not. So I don't know if that gets at what, I mean, it's not an answer, but it's kind of what
No.
and I fully.
I think it gets to the issue between short-term and long-term.
Right.
Right, which Tom brought up.
Right. And I think there also need to be a lot of people who work on the long-term solution. There needs to be the politicians and political science people who are working on governance and UN, and it hopefully all comes together to lead to development. Yeah.
Yeah, I just want to comment on both Albert's points on violence and the equity of interventions. A city we didn't talk too much about, but one where I've been doing quite a bit of work, Medellin in Colombia, recognized as kind of the poster child in the world for positive urban transformation over the last 4 or 5 years. So how did they go from the most violent city in the world in 1991 and 2 to now a city not in the top 100 in terms of gun homicides? They didn't do it through the aggressive policing and occupation that we see in some places in Latin America and particularly in the United States. They did a few things, and I mean, it's a complex story of transformation. But 2 things, get to Albert's point. One was a deep investment in public space, renewed public space. And that, what I mean by public space was transport, public spaces for people to come together. This was a city that was, everyone was behind walls and gates and in fear. So how do you open up a city for people to be citizens again and be peaceful in that interaction? It was not through targeted individual strategies necessarily, but a deep, deep investment in infrastructure and public space broadly defined. And the second, among other reasons behind that transformation, particularly and having significant health impacts, was something they called the ethics of aesthetics, where they put the new, most beautiful buildings, architectural competitions, museums, libraries, in the poorest neighborhoods. No other city in the world said, okay, we're going to build the newest library or public building and put it in, the equivalent of, say, the South Bronx or a neighborhood that has been chronically divested from and the poorest, say, in the United States. So there are strategies. There are things we can learn. It's not a one-size-fits-all, I agree. But how we value and think about the equity of those interventions and the role, what we can learn from some of this transformation that's happened in cities like Medellin, I think is critical moving forward.
Jason, could you just say something about how that happened? Was it community-driven? Was it a visionary leader? I mean, what was the process that made that happen?
Yeah, it's a complex story. Others have written about this. We've written about it. I think it was a combination of innovation in leadership. They had some very innovative mayors over a series of years, starting in the mid-90s. They had a plan of transformation, so plug for planning. And they did have strong community engagement. They did engage with violent gangs that were terrorizing neighborhoods. They did have strong community leadership. They have something that many other Latin American cities have now too, called participatory budgeting, where residents were able to prioritize certain aspects. I mean, it's a complex story, but I think it is a combination of having leadership that's willing to take risks, but that investment, that innovation is strong community engagement. And then they innovated in terms of technology with things that were not new technologies. They took a cable car for skiing and made that part of the public transport system, the Metrocable. Now we see that in Brazil and in other cities. They took the escalators that we see in the airport and used that to get up the steep slopes that Albert and others showed that are very common in Latin American barrios and favelas, et cetera. So innovation and socially, not necessarily through new technology, but these ideas came from the stories and narratives of community saying, this is what we think could work in our place.
Marcos?
Thank you. I just want to go back, which is building in your answer about experiences and linking it with the narrative of David. I want to propose a hybrid because I think if we're too slow, we're not going to make it. It's only 12 years for the SDG from now. And remember the MDG was 10, 15 years. The problem is, so I agree, it should be not slow, not too fast, but we should do. There has to be experiences out there, and you just mentioned one. There are favelas in Brazil that has been completely modernized in terms of security, that you can walk. I have launching restaurants in favelas in Brazil. So I think what we need to do is better job documenting these best practices. I read the Global Cities Report, Alex, of last year, and I was impressed from UN Habitat. I was impressed with how many sectors are getting information there, but health really behind. Correct me if I'm wrong. Not much. Just one mention of the SARS epidemic. Which brings me to the point that yesterday we were discussing and saying, we need to make sure health is in all policies, and that's the key issue. So to me is that we still, as health community, including WHO and including PAHO, including everyone, it's like, well, we know what we need to do. You know, don't worry. I don't need to talk to climate change people. I don't need to talk to, but it's changing. That narrative, to me, is happening now. In Latin America, which is the highest inequitable region in the world, we're seeing the famous social policies being rolled out. And in some governments, it's not happening like 20, 25 years ago, when a government implements something good, the next government completely shut it down. It's not happening. They are continuing doing that. Some of these policies, like, you know, Bolsa Familia was replicated in the whole Latin America, and several countries are doing it. You know, so to me, it's that we need to push, not to, but if we are too slow, we're going to miss the boat. Thank you.
Thank you. I just wanted to build a little bit, just for a second, on a point Alex just made. Was it Alex? No, sorry. Albert made, and Marcos made, and Alex made. Just because I think that a really, really, really important point is there, and I just don't want it to get lost. And perhaps it's a hypothesis, or perhaps it's actually an axiom. And that is that we really collectively, as people involved in setting the standards for health, must avoid cheap and substandard solutions for poor people's ill health. Just for one reason only, which is poor people have much less room for manoeuvre if things go wrong than rich people do. And that, I mean, that's from my clinical practice, my public health practice, my work at WHO, my work in the UN, everything I've done in 40 years has led me to say that. But stunningly, it's not actually what happens. That if you look at the design of interventions for poor communities, they are usually based on less robust and resilient approaches than are the interventions designed for rich communities. But Albert, you said it very explicitly. Alex, you've just been talking about it in relation to middle-sized cities. Danielle brought it up as well just now, and I think it's important. Sorry.
David.
Since we have Jason here, and he just made an urban planning kind of comment, I wanted to ask you an urban planning kind of question. And you spoke about Medellin and the example. By the way, I'm curious about whether there are any data on disease transmission with interventions of that sort. But this is going to sound like a goofball question, but the topic at hand the last couple of days has been focused on the problems that are associated with a particular spatial people arrangement, right? Slums and cities. So it's space and people and other factors, of course. But to what degree is that form of heterogeneity propagative of the problem? And so therefore, to what degree would homogenization of this landscape in a certain thoughtful way serve to mitigate the problems of disease transmission? I understand that making people less dense and so forth is going to cut down transmission, and there's science, of course, that would suggest that. But are there other more interesting ways of homogenizing an urban landscape or any kind of landscape that would address this problem of disease transmission in high concentrations of poor people, in this case around cities?
Save the easy questions for the end. I'm not sure what you mean by homogenization. I mean, if it's like all similar living conditions and standards, and I think we've had a lot of, we have a lot of evidence of bad planning that has gone in that kind of direction. I was talking to somebody earlier about the case of Brasilia in obviously the created capital of Brazil. And the part of that story was incredibly planned, perfectly planned, what would today be considered a smart or healthy city. Wide boulevards, lots of air, not so much density, beautifully designed by the best architects of the day. But the workers who came there to build that city built their own informal settlement off to the side, basically a slum, a favela. And that became the interesting part of cities. So I think, in planning, people on the edges of planning like me talk about health and disease and how planning relates to that. But mostly, we want cities because they're dynamic, they're fun, they're social, there are opportunities for lots of different kinds of expression. So I worry about the term homogenization because the richness of urbanization is diversity in some ways. So how do we maintain that diversity, both of the built environment, social dynamics, economic diversity, et cetera, while at the same time addressing some of the disease scenarios, the exposure scenarios, the risks that we've been talking about throughout this workshop, I think is the challenge that we clearly can't do alone in any one field, whether it's planning, public health. And this, I think, is what many people have been talking about, of bringing these different perspectives together to ensure we don't go down one of these dangerous roads that homogenizes and washes out the richness, the beauty, the culture that makes cities healthy, really at their core.
Yes, Alex.
I just feel I might be missing something if I don't respond to the point David Navarro made a bit earlier regarding not designing poor solutions for the health of poor people. At a conceptual stage, I agree with that. And many times, the solutions we bring to bear for very poor, vulnerable populations are often very poor policies and end up damaging them more rather than helping them. But I want to make the point that the solutions and the interventions that are needed are often simple and affordable. But we can only get to them if we work jointly with the communities. They don't have to be expensive, and they do not have to be things that we have tried in other areas or what is standard in other areas. I think the biggest concern that is there is really between having the best being the enemy of the good, that we want to wait until we can do the most scientifically proven and whatever intervention, that we forget to do the basic thing that needs to be done today, that we can do today. So how do we balance that as we intervene within these settings is really at the heart of how we will work with these communities. I just want to plead that there are things we know that could be done now. There are things many of these communities know could be done, that if we are willing to listen to them and work with them, with the resources that's available, we can make a significant difference in the lives of many people who live in slum conditions today.
Thank you for that important point. I would, Jason and Tom, Chris had to leave, but I would like to hear from each of you if you have one or two priority or final comments that you would make as we finish the session.
feel a little awkward doing this because there were so many other smart people in the room, so I'll offer this up and then they can comment. But in terms of a priority, as we've been going through this discussion, I really like the idea of something to follow up on this workshop. So another workshop that would look at cutting across urban development, modern cities, and public health. So getting more specific about how we would address these sorts of issues to improve public health. That is sort of a take-home for me.
Yeah, I would very much support that. I think there's been a lot of great ideas, energy, people connected in many ways. That empty feeling after you leave a really dynamic conversation or conference, and you go back to your maybe mundane day-to-day. How do we keep this going would be a key thing for me. And I think if and when hopefully that happens, to ensure that more community experts are in the room with us in the conversation, as many folks have been talking about. They are around, they are active in all kinds of global and local conversations, and having community leaders and community residents at the table with us, I think will be critical moving forward to solve these very challenging issues.
I would like to thank our moderators and thank all of you who participated and shared your good ideas in the working group. So thank you very much.